All right. Hey, everybody. Thank you, Peter and Patrick, for inviting me back to Bioilluminate for my second time being here. Looking forward to a great meeting. Let's see if I can work these slides. Here are my disclosures. My name is John Knob. You've already heard my introduction. I'm an anesthesia-based interventional pain management specialist, and I've been practicing since 1997. We've been using PRP and BMAX since 2015. And we do a lot of hips and knees and spine, shoulders and ankles, so kind of general practice. 4 years ago, I'd never even heard of Shockwave or EMTT, and now they're both an integral part of our practice, something I pretty much use every day, and I could not function without, or at least I wouldn't want to. So I'm going to try to explain why I like these therapies, tell you how I use them, and back up my opinions with some case studies and level 1 evidence. So you may recognize my town. Wilmington, North Carolina has both a thriving film industry and a thriving hurricane industry. We managed to evade this year's hurricanes so far. So I am a kiteboarder, and this day was epic. Okay, beautiful sun. Wind is blowing about 30 knots. Perfectly executed jump. Here it is in slow motion. Beautiful apex coming down softly like a butterfly. We follow that with what we call the tomahawk chop. Neck snapping, back wrenching, knee twisting, and I get up and do it again. This is a painful sport. And I admit it, no joke, my first motivation to get a lot of these devices was extremely selfish. I wanted to treat myself. So I tricked my partner into buying them. And it was like I was getting a 50% discount. So how might Shockwave and EMTT fit in with your practice? 2 words are all I need to make my argument. Big gaps. What do I mean by big gaps? So we get athletes of all ages coming to us with musculoskeletal problems, and they just want to feel better, as quickly as possible. We may know what the patient may need, but they may not be ready to spend the time or money on things like PRP, BMC, or even prolotherapy sometimes. So these are the gaps. Gap number 1, cost. Some people cannot afford orthobiologics, at least in my place. That's the truth. But they also know they don't want surgery or steroids, so they're in a pickle. What do? So gap number 2 is downtime, especially for in-season athletes. They are often unwilling or unable to shut it down after an orthobiologic procedure. And gap number 3 is efficacy. Cell therapy, newsflash, isn't always as effective as the patient or physician was hoping it would be. So what do? Shockwave and EMTT, that's what we do. All I'm proposing is the idea that Shockwave and EMTT fill in the gaps that exist before, during, and after orthobiologic treatments. Simple, right? So shockwaves were first used in medicine in the 1980s to break up kidney stones. This process involved dunking patients into huge bathtubs under anesthesia while gigantic shockwave machines broke up their kidney stones. And as an anesthesia resident, I was part of this. Here you see on the left, the green shockwaves are breaking up those kidney stones into smaller stones that could simply be peed out by the patient without surgery. And the interesting thing is that the shockwaves are focused in such a way that damage to healthy kidney tissue is avoided. And on the right, you see these huge mega tubs. And this was very stressful as an anesthesia resident, seeing this and having to participate in this. So it wasn't long before people started asking how else this device might be used. And this is the exact moment when a young Swiss orthopedic, probably with kidney stones, first asked, "Can I use these shockwaves to break up the painful shoulder calcifications?" Sure enough, it worked, and the field of shockwave therapy was born. So in shockwave therapy, sound waves are delivered transcutaneously to pathologic tissues where they exert a biologic effect on those tissues. And this process is referred to as mechanical transduction, or the translation of physical energy into biologic reactions. These effects can be either direct, where sound waves break up calcifications, or indirect, where sound waves act as triggers for a whole bunch of different biochemical processes, which I'll get into in a minute. There are 2 broad categories of shockwave, most common being radial shockwave and the most well-studied being focused shockwave therapy, with energy sources being electromagnetic, electrohydraulic, and piezoelectric. So in general, we think of focused shockwave therapy as being stronger and more effective for focal and deep areas of pathology. And while radial pressure wave does not penetrate very deeply, it is a much more efficient tool for treating larger pathological areas in the trunk and limbs. So EFD stands for energy flux density, which is a measure of the amount of power applied to tissue at a specified depth. On the left, you can see that the highest EFD is found at a point distant from the focused shockwave device. And on the right, you can see that the highest EFD is found at a point immediately adjacent to the radial shockwave device. The waveforms are different. The dark line is a focused shockwave. Focused shockwave devices create a wave characterized by a rapid rise in pressure, followed by a negative pressure wave, and this is a true shockwave. The dotted line is a low-intensity radial pressure wave, not considered to be a true shockwave. So the energy from the waves created by this dude's legs is radial shockwave. That's like radial. So the energy is strongest superficially at the edge of the body of water. Sorry for the pun. The energy from the waves created by the rock he threw is like focus shockwave. The energy is strongest deep within the body of water. Okay, got it? No more of that. All right. So there are 3 types of focus shockwave generators and only 1 type of radial shockwave device. Top left is a spark plug. That's an electrohydraulic. Bottom left is a piezoelectric disc, and top right is an electromagnetic coil. That's what we use. But today I think we're going to see the piezoelectric, or maybe yesterday you saw that. So all of them use electricity to generate a miniature sonic boom, which we hear as a little click. And this process creates a focal point of pressure at a fixed distance beyond the handpiece membrane. On the bottom right, there's a radial shockwave device, which is a simple pneumatic gun using the energy of an oscillating bullet going back and forth in the tube, which creates an oscillation at the applicator tip. With focus shockwave, we can concentrate energy of up to 1,000 standard atmospheres at a point about 5 centimeters beyond the handpiece membrane. The treatment zone is generally larger than the focal zone. It's a spherical region extending out from the focal zone, and we adjust the depth of the treatment zone with what we call gel standoffs. Treatment intensity, or EFD, is adjustable. It's measured in millijoules per millimeter squared. There are the standoffs that we use to adjust the depth of the treatment zone. On the bottom, there's a tall standoff placed on the handpiece. This allows for treatment of superficial tissues, so like MCL or a meniscal tear. And using no standoff allows treatment of pathologic tissues with this machine to a depth of about 6 centimeters and deeper. So this is a radial pressure wave device. The maximum treatment depth with this guy is approximately 3 centimeters. But as I pointed out earlier, it's a much better tool when you're targeting larger muscle groups. Depth is adjusted by using different applicator tips, and these are the applicator tips. EFD with this guy is measured in bar, which can be converted into millijoules per millimeter squared. So I think you already know the answer to this question. I get this a lot. There's a lot of overlap between the shockwave devices, but they really are 2 different tools, and you need both. I'm not selling any of these devices, and I do not work for any of these companies. So don't be this guy. I have drilled through my own finger using a similar technique. So how does this work? So the exact mechanism of action of shockwave therapy is unknown, but the biological response of tissue to shockwave therapy is known and includes increase in blood flow from nitric oxide release, increase in synthesis of collagen types 1 and 2, tenocyte proliferation, reduced pain due to modulation of substance P, downregulation of pro-inflammatory cytokines, and upregulation of anti-inflammatory cytokines. In cases of bone marrow lesions and osteonecrosis or stress fractures, shockwaves are known to promote the proliferation, activation, and migration of osteoblasts and downregulate the activity of osteoclasts. Shockwaves may also promote mobilization and differentiation of MSCs in the treatment area. So let's stop for a second and look at these potential mechanisms of action. They look familiar, right? So I was first trying to get my partner to agree to purchasing these units, and he was asking me, how many shoulder calcifications do we see in our clinic? And it wasn't until I asked him to think about shockwave therapy as being a non-invasive orthobiologic tool that the light came on and he agreed to let me buy it. I mean, these are some of the same things we talk about when we're listing the mechanisms of action of PRP and bone marrow concentrate. And so this is how I explain shockwave in simple terms to my patients. It's basically a form of non-invasive orthobiologic therapy. So let's look at a couple of level 1 studies as well as some case series demonstrating both clinical and radiographic improvements in patients undergoing shockwave therapy. We have level 1 evidence supporting shockwave for a number of diagnoses. This is a level 1 study in 245 patients with chronic plantar fasciitis. 2 groups, an active treatment group receiving 4 weekly sessions of radial shockwave and a placebo group receiving sham treatment with an air-filled standoff. At 12 weeks, at follow-up, there were a significant difference in first-step VAS and overall success rate in the shockwave group versus the placebo group, and these differences were further pronounced at 12 months. This same group did a follow-up study in 2015 using 3 weekly sessions of focused shockwave therapy, also showing similar superiority of shockwave compared to placebo in the treatment of plantar fasciitis. Here's another level 1 study in 40 professional athletes with chronic proximal hamstring tendinopathy. 2 groups, focused shockwave therapy once a week for 4 weeks versus traditional conservative treatments. At 3 months, there were statistically significant differences in the shockwave group versus the TCT group in terms of VAS, inertial phase rating scale, and percentages of patients reporting 50% improvement in pain. 80% of the shockwave group were able to return to full sport at 3 months with no re-injury during the 12-month observation period, and none in the TCT group were able to return to sport at 3 months. This is a systematic review meta-analysis from 2018 by Moya, showing that there are grade A or B, which means good or fair recommendations for shockwave therapy for many of the common MSK disorders that we treat. So these images are from a case series by Moya showing resolution of painful supraspinatus calcifications where shockwave was used as monotherapy. These results were achieved after only 1 to 3 sessions of focused shockwave therapy. Okay, bone marrow lesions. BML is a hot topic in orthobiologics, right? Did you know that you can also treat painful BMLs with shockwave? You can. This is a group of 86 patients with painful BMLs of the medial compartment of the knee. 2 groups, 55 received focused shockwave, 1 session every 3 weeks for 9 weeks, so a total of 3 sessions. 31 patients received no treatment, and at 3 months, there were statistically significant differences in VAS, WOMAC, and decreased size in BMLs in the shockwave group compared to the no treatment group. Non-unions, these patients are silent sufferers, walking around for months or even years with painful unhealed bones. This is a 14-year-old girl involved in a motor vehicle collision. Fracture consolidation was not achieved at the tibia at 12 months, and she was still experiencing severe pain during walking. So at 12 months after her accident, after her surgery, she received 4 consecutive sessions of radial. So remember, this is focused baby brother. She got 4 radial shockwave treatments, and these are the results. She was pain-free with walking at 18 months. And again, what's unique about this case series is that the lower energy radial shockwave devices were used to achieve fracture consolidation. Here's a common problem with the unique treatment option. Horizontal meniscal tear with associated ganglion cyst. This is a 41-year-old runner presenting with medial knee pain and positive McMurray's, and MRI and ultrasound images on the left consistent with horizontal meniscal tear. Picture on the right shows ultrasonic evidence of healing after a course of non-invasive focused shockwave and EMTT. Treatment included EMTT, which we'll talk about in a little bit, 8 hertz, 6,000 shots, energy level 8, and simultaneous once a week ESWT, so focus shockwave, 0.25 millijoules per millimeter square, 4,000 impulses, 4 hertz, once a week for 3 sessions. In addition to the obvious healing of the horizontal tear, shear wave elastography at 6 months demonstrated comparable stiffness of the treated or healed meniscus and the healthy contralateral meniscus. So let's talk about dosing. Most of us here appreciate the importance of dosing in the field of orthobiologics, and this is true for shockwave as well. Shockwave therapy is also highly quantifiable, and although more is usually better, this is not always the case. On the bottom right in green, You can see that even nano doses of focused shockwave therapy are now being proposed for the treatment of some neuropathic pain conditions. So I'll briefly go over contraindications as well as practical considerations of shockwave therapy. Very few contraindications to shockwave. These are the guidelines from the ISMST. Few clinical pearls that were not obvious to me and are not listed here. So I had some upper C-spine pain that I put a good, nice, healthy dose of focused shockwave therapy right up there. And you can hear it kind of going right through your bone, good bony transduction. Basically, I developed tinnitus for about a month after I blasted my suboccipital region. So I would not do that. I also was targeting my vastus lateralis, where I can develop some trigger points, and got up to pretty high energy levels, which I tolerated very well. But in the middle of treatment, I noticed I was feeling sweaty, nauseated, more so than my typical Saturday morning hangover. And I checked my pulse and I found out it was about 28. So I stopped treatment and laid down, and luckily it passed because I was there in the office alone. So if your patient is looking green around the gills, I suggest you lay them down and get them some cool rags and make sure they don't pass out on you. So in order to standardize treatments in our clinic, I have transcribed the various treatment protocols for each condition into our EHR to serve as a reminder of EFD, the number of shocks with each device, and the important structures of the functional spinal unit, or functional unit, excuse me, that we're treating. And these are the basic principles that we apply to most of our musculoskeletal disorders. So, this is for Achilles, but it's really going to be very, very similar whether you're talking about um, flexor tendon, extensor tendon, patellar tendinosis, so on and so forth. So this is a cash pay service for the most part. You have to decide how you want to integrate it into your practice. It could be 100% provider driven or a hybrid of provider and technician. Price per session depends on a number of factors, including the number of areas being treated. And once you get comfortable with this and familiar with it, I think patients understand that the more places they want treated in a single section, the more it's going to cost. These devices do require maintenance, so you have to factor that in. You don't give away too many treatments because you're going to be paying for the maintenance yourself at some point in time. So shockwave treatment is usually once a week, sometimes twice a week, depending on the indication. And we also use shockwave before, day of, and following cell therapy. Okay, here it is, the most important slide in the whole talk, so pay attention. This is my team who does most of my shockwave and EMTT. Megan is a PT. She's in the center. She's an amazing asset, especially with the shockwave. She really has transformed my practice. Another point, you've got to have an implementation plan in place before you start down this path, unless you're just starting out and you got plenty of time. Otherwise, you're going to spend the money on these machines. You're not going to know how to use them or when to use them, and they're going to sit in a corner while you're doing your day-to-day busy clinic stuff. So you also need to check with your local and regional regulatory agencies to know whether non-physicians are allowed to administer shockwave and EMTT. All right, so crash course on EMTT. How many people are using or familiar with EMTT? All right, so we were one of the first clinics in the US to get a machine in July of 2021. We've delivered over 18 million impulses since we got it. And with our average treatment consisting of 6,000 impulses per session, that's about 3,000 treatment sessions so far. EMTT has been in Europe for over 5 years with no serious side effects reported. It uses an electromagnetic field of approximately 0.8 Tesla, with most MRIs being about 1.5 Tesla. It penetrates to a depth of 18 to 20 centimeters, and its predecessor is PEMF, or pulse electromagnetic field therapy. This is what I call the 2-for-1 special. The magnetic field, of course, is present on both sides of the wand, so I'm treating both of my medial knee pathology areas simultaneously. So pulsed electromagnetic field therapy, or PEMF, is EMTT's precursor. EMTT wave in blue is more rapidly oscillating and also 40% stronger than PEMF wave in red. The mechanism of action of EMTT may be related to a reversible condition called electroporation, which occurs during therapy. This refers to a transient opening of pores in the cell membrane that allows nucleic acid and DNA and other proteins to enter the cell. On the left, you can see the 3 phases of electroporation: before, during, and after the electromagnetic pulse. And on the right is a representation of DNA entering the cell through a pore created during EMTT. Normally, this would not happen due to the highly charged nature of these particles. So EMTT is FDA approved for reducing spasm, increasing blood flow, and re-educating muscles and nerves. It's applicable to most body parts. It's a very easy to use interface, learnable in about 5 minutes, if that. When I tell my staff 886, they know what I mean. That's power level 8 hertz, 6,000 impulses. Treatment is well tolerated. Unlike Shockwave, which is 100% hands-on, the tech can leave the room during treatment with the EMTT and do something else, so it's very efficient. Typical session is about 20 minutes. Contraindications are basically the same as if you were sending a patient into an MRI unit. So I did erase on one of my Home Depot gift cards. We have our patients put their belongings in a small safe just outside the treatment room. Okay, so why did I get EMTT? This is kind of why I got it. We do a lot of spine, and this MRI is a great example of, types of spines that I see. We have an aging population in my area. I see this guy's MRI and I feel terrible, pessimistic. I mean, this has got everything. Modic change, inferior L1, entire L2, superior and inferior, and superior L3. He's got facet arthritis. He's got significant stenosis, and there's not a lot that you can do for this guy. So steroids don't work. PRP may help. IO injections into those vertebral body areas of edema is not really ready for prime time. So Intercept could help with the modic change pain, but not the stenosis. And, he already saw the neurosurgeons who were not at all interested in operating on it because he's got some lower spine pathology too. So there is emerging evidence that EMTT may help with painful bone marrow edema, and there's also evidence that it can help with non-specific low back pain. So this was the study that I looked at from 2017 by Gerdes-Meyer. He took 88 patients and randomized them to receive either 6 weeks of physical therapy and over-the-counter medications, or the PT and OTCs with 8 sessions of EMTT. Patients receiving both EMTT and PT did better in terms of VAS and ODI at 6 and 12 weeks compared to the PT alone group. So this terrible MRI is actually a patient of mine. He's a 69-year-old male who presented with a 6-month history of progressively worsening low back pain, axial, non-radicular, from L1 to L5, referred to me by the neurosurgery group, who, again, did not want to touch him. He was miserable. I gave him 1 epidural, and he was 40% better for 1 week. So I said, let's try this. I just got this machine. I'll give you a free treatment. And he did it and left the office kind of feeling 60% better. So his severe pain returned about 2 weeks later, and he asked if he could continue the EMTT instead of epidurals or PRP. We did Gerdes-Meyer's treatment course, 888, total of 4 weeks, 8 sessions total. And at 6 weeks, he was kind of like, not a lot better. So we started kind of coming back to traditional treatment discussions, PRP, radiofrequency. But 1 week later, at 7 weeks after treatment, while I was at a meeting presenting on Shockwave and EMTT, he texted me about 45 minutes after I gave my talk, saying, Johnny, just 5 days after telling you that it's not working, I am now reporting 80 to 90% reduction in my back pain. So I was happy. He was happy. We canceled plans for additional interventions, and he asked if he could get some more EMTT. He received 4 additional treatments, total of 12, and is now reporting ongoing relief of 90%. At 6 weeks, he was, so his 6 weeks after, he was kind of feeling a lot better. And this is his MRI at, I think, about 9 months after treatment, resolution of stenosis, improvement in the bone marrow edema, and he has not contacted me, which he definitely would if he was still hurting. So here's another much more common condition that seems to respond well to EMTT. This patient is now 57. It's me. This happened in the fall of 2021 after a kiteboarding injury. This is my MRI. It's a far lateral disc bulge at left L3-4, causing the most annoying numbness in my left leg, L3 dermatome. I now know where my left L3 nerve goes to. This is something we'd normally target with a transforaminal ESI, which I did not want. So I decided to follow Gerdes-Meyer's protocol for non-specific low back pain, put the wand in the region of my left L3-4 disc, just off to the left of midline. During treatment, I could feel non-painful pulsations in my back, but not in my leg. I apparently didn't read the menu or the recipe because I had no pain, no symptoms after 2 sessions of EMTT, have returned to full sporting activities and remain asymptomatic from that condition, at least for the past 24 months. So we're now using EMTT immediately after our spinal PRP and platelet lysate procedures, with the thinking that with EMTT, we are driving growth factors from the PRP and platelet lysate into the target cells as quickly as possible. Typical treatment is 888 following the procedure, then twice a week or once a week or twice a week, depending what the patient can get in for 3 weeks afterwards. Anecdotally, I'd say that my patients are coming back feeling better sooner than they would be typically before we started using EMTT. The final case, combination of Shockwave and EMTT. It's an 18-year-old female, friend of my daughter, who came to me in January 2022 with a history of right foot fifth metatarsal avulsion fracture, Jones fracture, 5 years ago, 2017. So after that initial injury, she had a long recovery course with multiple attempts at non-weight bearing, boot, casting, with eventual healing over the course of 2 years. So she went ahead and refractured the same area, being clumsy, in April of 2021 and had a persistent non-union. The ortho guys are telling her she needs an ORIF with plating and screws, and she's just freaking out. You know, she's 18, she wants to surf and hang out at the beach. Here's the x-ray of her fifth metatarsal, showing distraction of 3 millimeters, overlying soft tissue swelling, and no periosteal reaction. So she is not healing and has been 9 to 10 months since her refracture. I gave her 3 weekly sessions of focus Shockwave at 3,000 shocks. EFD was pretty low, 0.15 millijoules per millimeter squared, 4 hertz. And we did simultaneous EMTT 88,6000. So here she is getting her Shockwave through her UGG boot. I was a little concerned that she might not heal well because we could only get up to moderate strength on the focus Shockwave. And there were some gaps in between the sessions due to her traveling. But here is her x-ray at 11 weeks after her initial visit, showing complete healing of the non-union. She is also reporting improved range of motion of the 3rd, 4th, and 5th digits, which had been problematic for her due to long-term casting and booting. She does have some residual mild pain only when she's very active on her foot. She was offered some additional treatments, but she said, all good. So for the longest time, I was this guy. Don't be this guy. Stop being this guy, wasting your quarters on the single pain generator whack-a-mole game. We have to think comprehensively for our patients if we're going to get anywhere. Shockwave and EMTT are comprehensive, non-invasive orthobiologic therapies. So now when I treat someone with plantar fasciitis, I don't just treat the foot, I treat all the way up the kinetic chain, sometimes all the way up to the hip if I need to. Thinking this way and having the tools to help me treat this way have been a practice changer for me. This is my posse at Park City. 3 of these maniacs are my patients, and they're the reason I need Shockwave and EMTT. These people are busy, aging athletes. They don't always have time for 6 weeks of physical therapy. They know better than to get steroid injections, and they also know that they're nowhere near ready for surgery. And sometimes they're not even ready to shell out the cash for PRP, which is fine. Thank you very much for your attention. Please reach out to me if you have any questions, and enjoy the rest of the meeting. Thanks a lot.